This conference will now be recorded.
Well, good evening, everybody. It is December the 4th. Yes, December the 4th. This is the high-risk recurrent advanced prostate cancer group. The voice you're hearing is Rick Davis, and I'm in the hot seat tonight, and so we'll lead the group. We don't have any new people. A quick word of thanks to our sponsors who right now appear to be Janssen, Bayer, Foundation Medicine, Myriad, Sumitovant, that was Myovant, Telix. We're not sure about Pfizer. They've gone very quiet on us, so we may be having to drop Pfizer off. I think I got everybody.
Blue Earth.
Blue Earth. Thank you very much, Blue Earth. Thank you very much. And Frank Fabish, by the way, on Blue Earth, sent me a note about a new drug that he'd heard being tested, which I did look up. I wasn't aware, but it's I think it's called Prostlan, the trial. It's basically Blue Earth's version of Pluvicto, which they are testing out with some new ligand. I don't know, but they've put it into trial. I honestly don't know too much. I mean, we were expecting it because the ligand for Posluma, which is their diagnostic, which has been approved, has two uses. It can be used diagnostically and it can be used. Oh, no, I'm sorry. That's Blue Earth. I'm wrong. Telix, no, forget that. We are expecting Blue Earth to do a therapeutic. I wasn't expecting Telix to do a therapeutic. So that's news. Watch out for Telix's therapeutic. I get some of these trials confused, so forgive me for confusing you and everybody who's listening. All right, we will start off tonight with Mark Valens, since he said he had a bunch of stuff going on. So go ahead, Mr. Valens.
So when I talked to you guys 2 weeks ago, I had my first PSMA and my remission has turned into recurrence. I got my first bone met on the pelvis. And then when I was in the hospital for 4 days, turned out I had acute kidney failure, which came because the urine had backed up into my kidneys. And I now have 2 nephrostomy tubes that go directly through my back into my kidneys. And that's actually saved my life. My kidneys are doing okay now. It's really hard to get a hold of some of my doctors. Dr. Roach and Dr. Borno at UCSF. I finally get to talk to them tomorrow and the next day, but I've been waiting 3 weeks for that. So I went to a local radiation oncologist who seems very good. He's really concerned that my PSA is doubling every 2.5 weeks. So he wants to put me back on bicalutamide and Lupron. And then we'll see what Dr. Borno and Dr. Roach tell me in the next couple days. One thing I want to run by you guys is that you all really like darolutamide plus Lupron. And I brought that up to the local radiation oncologist, and he wanted to put me on bicalutamide. And so I don't really understand.
Okay, so, Mark, let me just explain. And this is where it gets really difficult. And this is why I know it's frustrating you can't get hold of your docs, but you got to have one quarterback because
Yeah.
your local guy is living in the dark ages, and that's the problem. Today, if you can possibly get it, the drug you want to be on is Orgovix, which is the
Okay.
pill. And the reason is because it acts quicker, and also your testosterone comes back quicker when you come off it. He's putting you on bicalutamide as a buffer. He's not putting you on bicalutamide to treat your disease. That's a good thing. He's smart enough to do that because the Lupron is an agonist, and it boosts the testosterone before it falls. When you're on an antagonist like Firmagon or Orgovix, it immediately drives down the testosterone. So the darolutamide and the bicalutamide are for completely different reasons. He's not even talking to you about a second-line anti-androgen, which he should be. And so, what you're getting is a guy who really doesn't keep up with the literature. He may be a decent radonc, I don't know. I'm not much impressed with his ability to manage prostate cancer. If it were me right now, I would be going for Orgovix. And if I can get it, my insurance will approve it. And if it was decided that you needed to go on to a second-line anti-androgen, which is really the call that Dr. Borno should make, then darolutamide would be our drug of choice here in this group based on the side effects.
What?
Can they hear you?
No, I've
And
got
then not do Lupron?
Orgovix is doing the same thing as Lupron.
Okay, gotcha.
Okay,
And then
Orgovix is an LHRH drug. And sorry, I'm just trying to turn my phone off here so that it's off now. Orgovix is an LHRH drug. You need to, yes, probably good idea to be on an LHRH drug, although we've talked about monotherapy here many times. But that LHRH drug, the best one to be on is Orgovix if you can get it. It's a pill.
Okay.
You don't need an injection. You take it every day. And the guys seem to like it better for many reasons. That said, a couple of things. Do you take a proton pump inhibitor?
No.
Okay, then you're good, because you've got to be careful with that. And I'm not sure of the other interactions, but certainly the PPI. But I think if you want to use a local radonc, that's fine, but restrict him to radiation oncology.
My preference is to go with Dr. Roach, but he couldn't talk to me for weeks. And I mean, I left messages and he said, I can't talk to you until I got more time. But the local radonc does bring up one thing, and I'll have to see what Dr. Roach says. He actually, the local guy, I got to give him credit. He contacted UCSF and he got the full record of all 26 days of radiation, of how many fractions where. He knows exactly how much I got everywhere in my prostate, and he's a little concerned about going back into the same area with more radiation.
Well, with a bit of luck, he can talk to Mac, or Mac, you can get them together and they can decide that. That's certainly way above my pay grade. But I'm just telling you if he's there talking to you about bicalutamide and Lupron, he's not up with the literature, because a recurrence today is usually treated not just with Lupron, but a second-line anti-androgen, which he's not even talking about. Bicalutamide is a first-line anti-androgen. And not in your case, but with multiple Mets, it would be also with chemotherapy. And he's not even in that space. So
Yeah, he made another point which I hadn't heard. He said most of the studies are about oleometastatic disease,
oligometastatic.
but he said there's not near as much study on oligorecurrence, and there's a difference. He says,
No,
and
that's
so we
not
should.
true either. That's not true because
Well,
we, I mean, there are, Len will give you the names, or one of the guys will give you the names here. But I mean, there are some very basic studies on recurrence, and they address the difference between oligo and more than oligo. So, what's that big study that's got all the different arms? Which one is that, Len?
Don't know the name of the study, but usually oligometastatic implies no more than 4, or some say 5 metastases. Unless they are out of the pelvic region, then it could be even just 2 or 3.
Len, which
Yeah,
was the study that had all those different arms? It came out of England, and that was the first one that said a few Mets go with second line anti-androgen, lots of Mets go with chemo.
oh, right. That was charted, wasn't it?
Charted, yeah. And Charted's been around for ages. Sorry, I'm just having a senior moment there. So again, this is a gent who probably doesn't keep up on the literature too much.
he seemed to know an awful lot, but I don't know a lot, so I don't know if he knows what he's talking about. But
Well, he's not, two things here. One is he should know about Charted, because that's where that was such a basic and a huge study. It's still ongoing. And the other thing is, if he's talking about bicalutamide and Lupron, where's he been with Orgovix? He didn't even raise it with you. Or Firmagon. He didn't even raise it with you. So that's a couple of things. Peter Kafka, what's up?
Mark, when you said doubling every 2 weeks, what kind of numbers are you talking about?
I'm up to now, what, 0.6? I had to wait to get the PSMA till I went from got over 0.2, and then since I got the PSMA, it's now up to it's up to 0.76 or something.
Okay, so it's still under 1. It's not
Yes.
like, okay.
He's concerned at the rate at which it's going up.
I would be too. Yeah. I mean, I watch that very carefully. How often do you do PSA checks?
I was doing it once a month. We're doing it every 2 weeks now.
Okay.
Anybody else have anything that they would like to contribute to this conversation about treating recurrence when you first see it?
Well, I can report back next week after I talk to Dr. Borno and Dr. Roach. Hopefully I know a whole lot more by then.
That'd be great.
Well, Mark,
Tell Mac I said hello.
That's been my journey for 7, 8 years, is watching my PSA every freaking month, and as soon as I start seeing any kind of movement like you're talking about, I'm on it. So I keep it. I've been keeping it low, but I've done a lot of different therapies to keep it low. So.
Okay, well, thanks, guys.
Pleasure. Okay, we're moving along, and we are going to say hello to Dr. Bob, because we haven't seen him in this group for so long. We thought he didn't love us anymore, but he does, and he's got a few things going on. So, Dr. Bob, and I will also say I'm very excited, truly excited, because Dr. Bob's going to be in Tucson in the beginning of January.
Middle of January.
middle of January. And I told Dr. John today, who said he was going to be in the group, but he's not here yet. So, we got a welcome party out for you and Missy, Dr. Bob. Go ahead, bring the guys up to date.
Okay, so I'm not sure that the last time I was here, but it's been a while. So I failed chemo, became castrate resistant come June of this year when my PSA went over 2. Started Keytruda because I had all the markings, MSI high tumor mutation burden, MMR, mismatch repair deficient. And Keytruda turns out that a small percentage of people on immune checkpoint inhibitors, which is what Keytruda is, can have hyperprogression, messing around with the immune system instead of allowing it to attack the cancer. In my case, it seems to have let the cancer grow rapidly. My PSA from June to September went from under 3 to 60. So obviously that ended. I'm a month out from my first Pluvicto. The PSA, which I had last week, is up at 90, which I know Pluvicto you can have an increase, but at least the rate of increase has slowed. My alkaline phosphatase went up, so I know that's not a great sign. Red blood cells, hematocrit, they're all okay. White count went down. I guess that's not unusual for Pluvicto, and yeah, that's where I am. Physically, I had started with palliative care about 6 weeks ago, so I'm on gabapentin 3 times a day, and that's really helped. And mentally, I'm feeling okay. I don't know if anyone on this call is done or familiar with ketamine therapy, but I did that about 6 weeks ago, a couple rounds, and that's brought my anxiety from like a 7 or 8 down to a 2, and so far it's been durable. So that's in a nutshell.
Tell us a little bit about, we'll get to questions in a minute, but just tell us a little bit about this ketamine therapy, please, Bob.
Okay. So ketamine is a short-acting local anesthetic, but in lower doses, about half the anesthetic doses, it can act like a psychedelic. So I had a series of 2 a week apart, mind out of body experiences. I had questions from my unconscious mind, and I got answers.
Wow.
Second time was not nearly as fulfilling. In fact, and I didn't get verbal answers. It was all visual and feeling. But the second time around, the first thing I got was, "You again. I gave you all your answers." So my unconscious mind was snarky with me. But at the very end of that second session, the feeling I got was, I can't kill your cancer, I can't kill your pain, but I can give you peace. So I can live with that.
And what is the gabapentin for? Is that neuropathy or
No, for bone pain.
bone pain? Okay.
Yeah, I was having a lot of bone pain in my hips and lower back, which is where I have some of the worst Mets. I've got at this point, I probably have about 15 Mets, give or take.
Whoa, so who's got questions? There's a lot that Bob spilt there.
The ketamine treatment it's a guided thing.
So I had heard about it from someone else, and I Googled ketamine therapy in my area or near me, and there were four offices that did it. The guy I ended up with is an ER doc, but he does this 3 days a week, and some do it intravenous. He did intramuscular, and I see a therapist weekly on Wednesdays. I did this on Tuesday. So, it gave me time to process before I then talk the next day. Um, I don't know if there may be offices where it's more integrative, where you have a therapist there, but I just felt, I've been seeing a guy for, 18 months. I wasn't about to start with somebody new just for this. And again, I didn't know what to expect going into this, but it made a profound difference in my attitude. And certainly, if you got a lot of anxiety or depression, it certainly might be worth looking into it at the very least. So,
Hey, everybody. It's Larry.
Hi, Larry.
Hey, so this reminds me of, back in my college days when wasn't so much ketamine, but it was psychedelics, LSD. And I had this trip in Florida in the Everglades, kind of an amazing experience where it kind of helped me connect myself to the earth and totality and all of those questions and things. And in the middle of that trip, it said to me, or I was told, like, okay, now you've been here. Now go back to your life and go about your business. And it must have been 6 months later, I was back in Syracuse or graduate school, I forget. And and I took another trip, and I got to the place where it said, "Now you were you knew not to come back here. What are you doing here at this time when you have other things to do with your life?" And it was a horrendous, horrible 2 day miserable trip. And that was it. I've been reluctant to ever do that again. But I remember that experience so vividly. So when your body tells you don't come back, don't go back.
yeah, I mean, the ketamine lasts about 40, 45 minutes. And I'm thinking my unconscious mind, has things that have been buried for decades that it doesn't want me to see. So as long as, and they've shown in studies that ketamine or psilocybin, which is the mushrooms, can actually rewire some of the pathways in the brain. So as long as it's durable, I'm not going back. But somewhere down the line, if I need to, I'll give it another try. And yeah, I think it's Johns Hopkins started a trial where they're actually bringing ketamine therapy and talk therapy into cancer centers. I think at Hopkins and out in UCLA, and there may be other sites that they're just starting up with.
Yeah,
So,
they are. And if any of you are interested in exploring some of these thoughts more extensively, I think we'd really recommend you to Mettle Health, Mettle Health. I'll try and, I think it's mettlehealth.org. I'll try and put it in the website. Mettle Health is BJ Miller, Dr. BJ Miller's organization. He's no longer practicing medicine at UCSF. As you know, he's on our advisory board. He's the most amazing palliative care doc. And he's looked at these areas of psilocybin, ketamine for a long time. So he's really knowledgeable, but both from a mental health standpoint and from a medical standpoint. He helped prepare Ken Anderson, God rest his soul, to do psilocybin. And I think he does charge, they do charge. They know us very well. BJ knows us very well. But Mental Health and BJ are a great resource. So I would say think about that. Anybody? Len, you have your hand up.
Yeah, Bob already answered a few of the questions I had about ketamine, but I also have a question about the gabapentin, which I think is a little bit of an unusual choice for bone pain relief as opposed to, the usual opioid path. Or are you already taking opioids?
So when they started the GABA, they started it one day a week, or once a day for 2 days, then twice a day for 2 days, and then finally 3 times a day. And I was really hurting, so I was taking hydromorphone along with it, but that just zonked me out. But the GABA brought my pain from like 7 or 8 down to a 1. So, I think they just wanted to start with perhaps you know, something that wasn't an opiate and see if it would work, and it has. And then they also have me signed up. Penn has a trial program where they call Making Marijuana Easy. So I've got 8 months of free medical marijuana product from a dispensary here in Philly. I can get 1,250 milligrams of THC per month. And when I have to renew my card, they'll pay for that. So I just have to fill out a survey every month. So,
Well, I've heard that THC can aid the pain-killing effects of opioids, but by itself, I don't think it'll do anything for pain.
yeah, I'm using it more to help with sleep.
Oh, okay.
And then low dose for, I'm not sure if it's from the Pluvicto or from the GABA, but I have a little bit of low-grade nausea at times. And instead of popping Zofran all the time, the low-grade THC, or low amount, seems to be helpful. And I can always do the Zofran as needed, but figured give it a shot. And I've been using the tincture to help with sleep for probably a year and a quarter. So
I'm sorry, what was that? What were you using for sleep?
I've been using a tincture of THC and CBD for over a year.
Okay.
Not so much to go to sleep, but to get back to sleep after I invariably wake up to use the bathroom. It seems to help with that.
Okay, thanks. That's
Sure.
it for me.
We have another question. Who else? Jeff Marchu. Go ahead, Jeff.
How many milligrams of gabapentin are you taking every day, every time?
It's 300 milligrams 3 times a day.
That's exactly what I take I take 600 actually. I have osteoarthritis and one of my knees is just killing me, but with 600 milligrams 3 times a day, even though it hurts sometimes, it really knocks down the pain.
Yeah, I was a little skeptical, but it's so far it's working pretty well.
I dropped back to 600, 300 3 times a day, and the pain was really, I couldn't take it. I went back to 600 3 times a day. If you're getting relief with 300, great.
Yeah, no, I'm so far so good as far as the pain.
Peter Kafka.
Bob?
Yep.
Apart from the PSA jumps, did you have any other markers that Keytruda was affecting, like your liver or your pancreas or your thyroid, or nothing else was showing up?
Yeah, nothing else. And the PSA, when I got the PSMA PET scan, it showed a lot of progression, and that's like, okay, we got to stop this.
Interesting. Okay.
Yeah. I mean, if anyone's really interested in ketamine, I'd be glad to talk to them, offline. Just send a message in the chat.
Or send a message to dr.bob@ancan.org.
Okay.
So if you want to do it after, I'll put it in dr.bob@ancan.org. That should go to everybody. There you go. So Okay. Well, I think we should. Is there anything else? I mean, this is an interesting discussion, and especially around the psychedelics, which we rarely have here. So I just held with it a little bit. Is there anything else anybody wants to ask or raise before we move on? Dr. Jack, we haven't heard from you at all on this one.
I have nothing to add. Nothing
Okay.
specific.
Okay.
David Muslin here. I'm curious, how long were you castrate sensitive for, and what drugs were you on while you were castrate sensitive?
So I was diagnosed in May of 2022, started on Lupron, then abiraterone, which I had to stop before chemo because my bilirubin went way up. Did chemo by January, about a month after chemo was done, I went on abiraterone. By January of 2023, my PSA, which was 28.2 at diagnosis, was 0.48, and then it started to tick up. And by June, it was over 2, and tried swapping dexamethasone for the prednisone with the Abby, and that didn't help. So basically, from diagnosis till castrate resistant was just a little over a year.
Got it. And
Now,
what was your Gleason score, Dr. Bob?
4+5.
Thank
And
you.
it was all high volume. I was 70, 80, 90%, and I was de novo high volume metastatic.
And I do want to make one point that Bob and I discussed the other morning, which is encouraging, which is that before Bob started the Pluvicto, they did do concordant. They did look for concordancy, and Bob was very largely concordant. There were none, if any, lesions that seen on the non-PSMA scans to the PSMA scans. So that's a really good sign. So we're keeping our fingers crossed that that Bob will respond real well to the Pluvicto. And as I've told him, be patient. I think, Bob, you told me that the rate of increase of your PSA has dropped by 50% since you started the Pluvicto, right?
That's what it seems. I mean, I don't have, too many data points, but that's what it seems. So we'll see what happens, but thanks.
Okay. All right, we're going to move on because I am watching the clock here. Yeah, we don't have any other hands. Let's go to Fred Matika. Fred, what's on your mind today?
I just I just want to give an update. I'm fairly new to the group. I came to it I think about 8 or 9 weeks ago, and because I had stopped checking my PSA for 10 years. Anyway, my doctor pulled a PSA test on me, and my PSA was, make a long story short, was 15. In 2 months, it doubled, went up to 35. 2 months later, it doubled again up to 70, and it was shooting up like that, and I expected it to be about 40. When I went in, finally, I took some advice from the group here, and I did not do Lupron and Casodex. I went with the Firmagon, and that was in October. At that time, when I went in, I had started feeling symptoms of a shingles outbreak on my right rib cage. The nurse looked at it. She said she didn't think it was shingles. Well, I had shingles before, and I was pretty convinced it was shingles. She gave me my first injection of Firmagon. Went back in a month, and my PSA that I had that was in the 70s on paper, it was probably higher. My PSA had gone down to 0.73, and my testosterone went from, let's see, I don't have a testosterone current number, but it was about 600, and that dropped down to, I guess they called it undetectable, less than 2.5. So that's kind of where I sit with that. And I just, I felt pretty good about that. So I kind of wallowed in that euphoria for a while, just because it felt pretty good. And so I've had my second Firmagon injection, and my main problem, believe it or not, is not cancer. It's this shingles outbreak, which is pretty nasty, very painful. And I too am on gabapentin for that. I tried some opioids. I don't like opioids. I've never really taken many pharmaceuticals in my life, And so I took one opioid, and my God, it just made me gag and made me sick, So I went back to Tylenol 3 and some acetaminophen. That helps a little bit. I mean, I'm bearing up with this pain, and I've just started the gabapentin. And of course, while you guys were talking about this, I was just thinking, well, wow, I wonder, does that have any effect, on the Firmagon? I don't think it does, but it
So,
was just those were
Fred,
thoughts going through my head.
Fred,
I think that's it.
a couple of questions.
Yeah,
I know that in August, your PSMA showed that there were 2 spots in your sacrum and the ilium.
right.
How have those spots been handled? Have they been radiated, or have they decided not to radiate them?
No, there's been no real discussion about that, except when I brought it up, and my oncologist said, well, let's just continue with the Firmagon, and we'll address that, later.
Okay. Secondly, are you still with the same doc, or have you identified a genitourinary medical oncologist?
I'm with the same guy at
Okay.
Compass Oncology, Dr. Cosgrove.
So here's the same issue. I'm going to speak candidly. The other guys will talk to you, but this doc isn't treating you right. And the reason he isn't treating you right is that today, as we mentioned earlier on to Mark Valens, when you have a recurrence today, the protocol is to add a second-line anti-androgen. And if the doctor isn't doing that, he's not up with the literature. And we know from the trials that are done that adding a second-line anti-androgen to the first-line anti-androgen, which is the Firmagon you're getting, gives much better results. And maybe even better, and I can't remember these studies, but maybe one of the guys will, maybe even better than that when you add spot radiation. And he doesn't want to talk about spot radiation, and he hasn't even suggested adding abiraterone or enzalutamide, apalutamide, or darolutamide. Now that to me is, I don't want to call it malpractice, but he's in the dark ages still. We don't treat recurrence that way anymore. And it's all well and good now, and the fact that your testosterone went down and your PSA plummeted is exactly what should have happened. If it hadn't have happened, we would have been concerned, but it's exactly what we would anticipate to happen. So there's nothing special about that. What is your testosterone? What is your PSA right now? Is it still at 0.73?
Well, that was the last test that I had.
And when was that?
That was on species received reported November 15th.
Okay. So, and at that point, how long had you been on the Firmagon?
I went on the Firmagon in the middle of October. So that'd be about 6 weeks?
Right. So,
week.
I mean,
Yeah. A month.
That's a good result. However, what we would say is by now, and you should probably be testing monthly, it should be down to way less than that. And if it isn't, we got to be talking about something, and you know your doc should be monitoring it like that, because if what we would hope to see when you do this is for your testosterone, your PSA also to be insignificant. And if it isn't, then they should be already talking about radiating those spots and adding a second line anti-androgen. Your doc's not doing any of that. Now, what we said to you before is get your ass to a genitourinary medical oncologist, because for them it's second nature. They know what they're talking about. And these guys who are in the boonies and don't practice a lot of prostate cancer, they cannot keep up with what's going on because it's moving so fast. This is a huge, huge message. Get a GU medical oncologist, because already tonight we've seen twice where practitioners are not, they're not following the protocols.
And I'm a little bit at a loss for exactly how I should do that. I've looked around and called around, and you know, my last hope of finding anybody better based on what I did in research, was possibly at OHSU. But I know you've told me, and I've checked and called them, that some of their best doctors have left OHSU. They may have left behind people that they have worked with and trained and things like that. But if anybody knows that, if OHSU is my best
Okay, but there are still some very good. There are genitourinary medical oncologists at OHSU. Are they as good as the ones who have left? Maybe not. We don't know.
Right.
But they're a heck of a lot better than the guy that you're seeing. I mean, I can tell you that. Now, I think I have bookmarked, and I'll just look for it, but I think I have bookmarked the GU medoncs at OHSU. I know for sure they're easy to find because I was looking for somebody else. We're working with a lady in your area around Vancouver whose husband has very serious renal cancer and needed to switch. And so I looked for her. But yeah, you got to call OHSU and say you want to see a genitourinary medical oncologist as soon as you can. And you know that it's easy to do.
It is.
But right now you're not getting the right treatment. I mean, you can come on here, guys. I'm gonna just copy this link and put it in here for you. I'm going to copy the link. And guys, anybody else want to talk to Fred about his treatment path?
I just want to say that I am registered there at OHSU. It's just a matter of getting a referral. They will require a referral for me to go over there.
Well, okay, so we got two people, Len, and then we'll go to Larry Fish. Len, please go ahead.
Well, I guess just to reinforce Rick's message, Fred, you are not receiving standard of care. And, you know, we don't give medical advice, but we know what standard of care is, and you're not getting it. So I completely agree with Rick that you need to find a GU medical oncologist.
Okay, thank you.
Sure.
Len and then David Muslin. Larry and then David Muslin. You're muted, Larry.
Who's it we're talking to, Rick?
Fred.
Who's the person? Fred?
Fred.
Yes.
Fred.
Fred. I want to tell you that 3 years ago, I was on a single anti-androgen, Lupron, and other stuff. And my PSA started going up, and I went on a second darolutamide. I went on a second level androgen, which was good for a year and a half. And a year and a half ago, I had a couple of mets in my spine, and I did spot radiation. And now it's a year and a half later, and my PSA is undetectable, and I feel great. So I want to say that I've gotten 3 years from that point that you're
Wow.
saying your doctor stopped treating you. That's 3 good years, and uh, what everything that Rick and Lynn are saying. It's crucial to act now before you start to develop other metastases. That's all I have to say is I just got 3 years based on following this standard of care protocol at this time.
David
Very good.
Muslin.
Fred, I just want to empathize with Fred how hard it is to call a new doc and go see a new doc. Sometimes it's really hard to do that. And you've been with a guy, you trust him, you like him, but listen to what these guys are telling you. You've got to find another doctor, because I have the same experience that Larry Fish had. But just get the courage and make that call and go find the right genourinary oncologist. It'll change your life. It'll give you years of life, because you're not getting the right standard of care. But make that call. I know it's hard, but make the call.
Okay, very good. Thank you. And Rick, you mentioned, I think you mentioned 3 of these second line anti-androgens that should at least be added to the Firmagon. But of course, you said that quite rapidly, and I didn't get
Okay.
that. I'm wondering if you can write that over in the sidebar or something.
Okay. Somebody will put those in for you.
Okay.
The 4 anti-androgens, but rather than getting worried about which anti-androgen, and you can come back to us when they suggest something, and we can talk to you about that. The
Okay.
importance is that you add one of those anti-androgens. That's the discussion you should be having, rather than, we can tell you which is better, but we don't want to go there right now. Step by step.
I agree.
I put the link in the chat window. You can just click on that link and it'll open in your it'll open up for you. I'm just looking through here. There's a young woman. She's quite impressive. I've seen her deliver. Her name is Alexandra Sokolova. I think she knows her stuff. There's a guy, I believe it's accepting new patients, Mark Garzotto. I think one of our guys is with him. But when I look at this, I've got 1, 2, 3, 4, 5, 6, 7, 8 of these docs are accepting new patients. Now, Dr. Vuki is gone and Dr. Beer is gone, and Julie, I forget her last name. She's not there, but at least these guys' fields. And by the way we find out how good doctors are is by somebody's got to try him out for us and come back and say, oh, I really like this guy, or oh, this guy had a terrible bedside manner, and that's how we learn. But the only one that I can tell you I heard, and I've heard her present, she's young, is Sokolova. She's done some good research.
Are these people at OHSU? Is that what you said?
Yes, sir.
Okay, yeah. And
okay,
this is how I was just going to say, and this is how I learn, by having you guys talk to me like this. I appreciate it.
Okay. We're going to keep moving along. That's a pleasure. Anybody else? Anybody else have anything to say to Fred Matika, or am I clear to go? Okay.
Fred, you going to do it? Fred, are you going to do it?
Yeah, I'm going to do it. Like I said, I'm already registered. I'm going to be on it tomorrow.
You promise?
Good man. And then report back.
I will.
Thank you. Okay, Mike Wynn, you said you had a quickie question for us.
Yes, I need about a couple, 3 minutes, and hopefully nobody can yell at me. Okay. Essentially, I've been attending multiple virtual meetings all over the country, different groups, and essentially for the last 2 years, and essentially I have a quick conversation with multiple leader of some of the support group. So I hope that's what I'm proposing right now for the group, and especially to Rick, which is the leader of the group, is not going to be too naive in my part. What I'm thinking about is that, is there a possibility that we can go to and get an umbrella organization to connect all the local support groups around the country. We have a small group in Boulder with 30 people. AnCan, we got Reluctant Brotherhood, we got Fans for the Cured, and we have a group for Gen Married, okay, and so on and so forth. And then of course we have Zeros and US2 and Move Member, so on and so forth. So what I'm suggesting is that they have an organization consists of patient for patients, bottom up with one voice. And I'm listing out 8 things I can read for you. The first part of that is that.
Let me stop you, because what you're saying makes perfect sense.
Well, go ahead.
You hear me through. I'm sorry to
Yes,
interrupt you, but we don't have the time to debate this at length. I'm happy to talk to you offline. But as Len knows well, and Len's only been in this game since 2013 or 14, right, Len? 2013. I've been around this since 2007. And when I came into it, it was my vision that all the groups should get together and cooperate and have one patient voice. I can tell you now, based on 16 years experience, it will never happen. The groups, we're happy to work and collaborate with anybody. And if somebody wants us to push their group in a particular area, we'll figure out a way to do it. If you ask people to put our name out, most of them don't want to do it, and especially if they're already a nonprofit, because they don't want to dilute their funding sources. And for us to get everybody round the same table to talk is impossible. We've tried. They won't talk to each other. In theory, it's great. It should happen. It would be wonderful if it did happen, but it won't happen. It just doesn't happen. I've been trying to do it.
Right.
Very, very quickly. You wanted 3 minutes.
I want to be quick. Okay. What I'm proposing is that essentially we still have an autonomy of each individual group. However, there will be an umbrella organizations above so that we can have a force to ask Congress to put more money in funding for education, for prevention, for treatment. Why can we?
It won't happen. Zero has that space. They don't want to give it up. They won't even support you.
I will be talking with Terry from the Zero people.
Save your breath. It's not Terry.
Can I add something else?
No. You have to listen to what I'm saying. You're getting the
I do.
benefit of 15 years here, okay? Terry is a support group leader. Terry has no standing. If you want to talk to somebody, it's Jim Schrate, who's on their board. Or you go to Courtney and you talk to her. Avoid Ali Manson. She's a pain in the butt. All right? Now, it won't happen, Mike. You can spin your wheels as much as you want. I wish you the very best. We'll support you any way you can. But this is it's a fool's errand. I mean, Peter or some of the guys who have been around here a long time. Peter or Len, you have your mic off.
Yeah, Rick's telling the truth, Michael. It will not happen. They're just too protective of their source of funds.
So I understand all the stuff. I talk to people. I understand the personality. What about AnCan? Can you invite Congress people, newspaper people, somebody meeting right here so they can hear of you? Can you do that?
If you want to do that, you're welcome. It's not our space.
Okay.
There are certain spaces we don't want to get in. We don't have that advocacy. When I have tried and helped out Zero with advocacy, they've spat at me in the face. Because they do a crap job, if you want to know. In my view, they do a lousy job. But when we try to help, they don't want to know from us. When they needed speakers for local in local state governments, we found the speakers, even though they've got 30,000 people on their mailing list, because they don't even know how to go out and get it. Do I sound angry? Yes, I am. Because they get thousands of dollars and we get bubkiss. But we could do it. but it's not our space. Same way we won't go into LGBTQ space, because that's Middledorf space. And then they start snapping back at us. Mike, you've got to understand the dynamics. They're not what you think. It looks great in Colorado, in Boulder, where you're sitting in Boulder. Well, let's all play in the same sandpit together. We happen to be very collaborative, but we're about the only group who is. We've been trying to get a black men's group together forever and a day. You think Peahen? You think Fen will work with us? They're not interested. We'd love to do a black men's group like this, support group. They won't do it. Last comment on this goes to Peter Kafka, and then we got to move on, because this touches a chord with me, because I want what you want, Michael, but we've had to create our own organization over. We've been a nonprofit since 2016, and we've created room for ourselves, but we are tiny. We have 2,700 people in total. On this mailing list, we have 630 people. It's nothing. Because other people don't want to tell folks what we're doing. Peter, you have the last word on this, and then I'm moving on. You're muted, Peter. You're muted. Start over.
Mike, another telltale thing that I've always wondered about, and I've written to my congressmen and senators about this, is that within the Health and Human Service Department, there's an Office of Women's Health, because women speak up. There's never been an Office of Men's Health. They've tried a couple of times over the years, but it's never happened. It's never taken hold. And yet, most of Congress and both the Senate and the House are men. And how many men have had prostate cancer? Many of them have. And yet they don't have the wherewithal to see that there's a need to address men's health issues. So, I mean, even at that level, they're not listening or paying attention to their own bodies. So that doesn't mean we give up the fight. I'm not saying we should forget this, but it's an important thing. But we got to keep pushing on ways that work.
Okay. Anybody can reach out to me anytime offline. If they have creative ideas that are realistic and they need our support, we're happy to give it to you. But you've got to know the space. You've got to take the time. Please just don't walk in here with pie in the sky ideas, because you're pissing in the wind. But we will support. And if you can find anybody for us to work together with, we'll work together with them. And I will always stand by that. My board will stand behind me, and my key volunteers and advocacy people will stand behind me. We are more collaborative than any other prostate cancer organization that's out there. Okay, let's go to Gary Z. Gary, what's on your mind?
Thank you. I had a consult with Radonc, the person who gave me radiation in 2016, intensity modulated radiation therapy in 2016. This after about a month ago, the PSMA PET showed the 0.9 by 0.9 centimeter lesion in the right internal iliac node. The Radonc suggested in this initial consult that I get proton beam for a period of approximately 5 to 7 weeks with a cumulative amount of between 60 and 64 grays. The last thing I'll say, the Radonc said there's a quote 10% I guess possibility of complications to the sigmoid colon due to the location um, location in the, let me make sure I say, yes, the right internal iliac chain. I think, if just a comment, I think some of the helpful comments tonight regarding radiation has partly answered my question. I'm a little, I feel bad saying it, but I was a little underwhelmed with, in 2016, having 40 days of IMRT. I did get 1 year of undetectable PSA. Very grateful for that. I do want to get a second RADONC opinion, if anyone, and that could be maybe offline. I'm sorry, one other factor, RADONC is consulting with a colorectal specialist. RADONC said very low probability, but a surgical approach regarding this area that I mentioned. You know, I don't want to be a guinea pig in experimental surgery, so I won't say any more. I know that's a lot of information. That's the update that I have.
Let me just clarify something. Did you say they're recommending 6 weeks of proton beam?
Yes, approximately 6 weeks with a cumulative total, if I'm using the right term, you know, around 62 grays.
Okay. And what are they going to be radiating in this period of time?
It is the right internal iliac chain, and the RADONC confirmed that this area was not treated in 2016 in the 2016 the intensity modulated radiation therapy. He claims that the proton beam may reduce the possibility of complications.
And who is the RADONC that you're seeing?
It's Samir Kanani, Fairfax, Virginia.
Oh, okay.
Okay. Well, I think the first thing I'd suggest you do is go see Sean Collins.
Hey,
I have heard. I'm sorry. I have heard you mention his name before. Thank you.
Yes. Yes.
So I'd get your ass over to Sean Collins and see what he suggests. I can understand why they're recommending proton beam for you, because if you've got issues around the sigmoid colon, then it might be a better option. But you can talk about that candidly and with Dr. Collins. He's very, very good. You know, I don't know why you would need as much as 6 months, 6 weeks, if they're just doing that spot radiation, but then that could be something to do with the proton beam, which I don't know enough about, but Peter Kafka will talk to it momentarily because he's had proton beam. Peter, why don't you address that now, and I'll just find Dr. Collins, by the way, Jim Marshall, is not enough because he's got a brother who also practices. So you have to be careful. It's Sean Collins that you want to see. And I think his brother is also a RADONC, if I remember correctly. Somebody might know here. And I'll put his link in the chat window for you right now, Gary. And Peter, go ahead and talk about what you did.
Thank you.
Yeah, I did 10 days for recurrent lymph node out in California with proton beam, and it was successful. It was fine. It was only 10 days. Originally, it was scheduled for 20 days. 6 weeks seems like an awful lot for recurrence, particularly to And I guess my question comes up is if you did 40 days of IMRT, I would think they would have radiated the pelvic girdle in those 40 days. I mean, that's kind of part of the game. At least it was for me in my 39 days. And the iliac is on the pelvic girdle. So I'm just wondering about that. You know, how accurate you've got the previous radiation information.
Yeah, thank you, Peter. You know, honestly, when I had a consult prior to RadOnc with my GU oncologist, when I saw her, she had had a brief communication with Kanani. And at that time, Kanani's answer was, quote, to answer to GU oncologist question, did you already radiate this? Kanani answers, yes and no, unquote. So I asked Kanani about that in person 2 weeks ago, and he said, "Well, I didn't have all your, file up, and I don't want to disparage him whatsoever. But as a complete layperson, also with the knowledge, according to my GU oncologist, that 40% of patients are over-radiated. When he is talking about 5 to 7 weeks, I can't speak to the treatment total, the therapy, 64 grays, because I just haven't educated myself. I was surprised. I think GU oncologist, she actually told me, yeah, it might just be for a week. So I will try to contact the office of Dr. Sean Collins tomorrow. I give you my word. And Peter, thank you for letting me know. I am uncomfortable. It just, it's kind of, I guess it's good and bad news that Kanani is saying that, okay, well, you didn't treat the area, but what the hell did you treat? I'm sorry, that's probably not a fair comment.
Well, was Kanani who did the original radiation? Kanani?
Yes, Kanani, correct.
I mean, he should know what he treated in the first. I mean, he doesn't have to go anywhere to get the records like that good radiation oncologist, or not necessarily for prostate cancer, but he did the right thing for Mark Valens. And he doesn't have to be doing that, so he knows what he treated. But maybe I don't know what he did the first time.
I thank you, Rick. I want to underscore I don't think it's fair for me. I don't have enough knowledge, nor will I ever have enough knowledge. I don't mean to disparage Dr. Kanani at all. I don't have I think some of the questions you're asking, some of the other doctors' comments, right? My GU oncologist, it's just I have a slight uneasy feeling. So thank you. I will follow up with I'll contact the office of Sean Collins tomorrow.
Okay, I put a link. I don't know if I'm sure you'll find the office number, but there's a link to Sean Collins in the chat window. Just click on it. It'll open in your browser, and you can read it afterwards.
Yes, I see it now. Thank you, Rick.
Okay.
And Peter, thank you.
Anyone else have anything that they'd like to say?
Let me say one thing. The IMRT you had in 2016, is that right?
Yes, doctor.
Yeah, the thing I wondered about, because I remember talking when initially I was being considered for this kind of treatment until I found out it was outside of the pelvic bed. In 2016, I don't think they were routinely doing the pelvic bed. They were doing just the prostatic fossa. And I think the papers came out saying it's good to do a prophylactic combination of both the pelvic bed and the prostatic fossa routinely, even if you don't see anything in the pelvic bed, because you get a long-term better result and less of a chance of getting a recurrent node like you've developed. So I don't think it was a blunder. I think that was just routine care back then. I think. Rick, correct me if I'm wrong.
Sorry, routine. You're saying back then routine care for pelvic girdle radiation, Dr. Jack?
No pelvic girdle radiation, just prostatic fossa. And then,
No.
Oh yeah, sorry. I'm sorry. I was responding to somebody who sent me a question in the chat
and
window. Yeah, I mean,
I thought the literature came out, at least according, that
no,
more
no, no, no,
recently, within the past 4 or 5 years,
no. The-
they do.
No, the
No, okay.
literature's been there. The literature's been there for years. I mean, Mac Roach has been pushing pelvic girdle radiation for recurrence and also for advance for years and years. But
Oh,
many radiation oncologists didn't want to do it. So all they
okay.
do is the fossa and God
Yeah.
knows what else, and it was stupid because if they thought it was in the fossa, it could just as easily be in anywhere else if it had micrometastasized there. So the question you need to ask Kanani is what did you radiate originally, which I think we raised when you were here last time. What exactly did you radiate? Did you radiate the fossa? Did you radiate what they call a rabbit's ear pattern, which is kind of two rabbit's ears that go up on either side of the prostate, like two long rabbit's ears that go up on either side of the prostate, like these mule rabbits that I see, these jackrabbits that I see out here. Or did you radiate the whole prostate girdle? What did you do? And that's going to be important because when you go see Dr. Collins, he's going to want to know that. So when you speak to Kanani, you tell him, I would like a full history of what was done originally, because you're going to need to take that with you.
Okay, I will definitely follow up with Kanani. Thank you
Drill
all.
down. And you're still you're at Inova Fairfax. Should be easy
Yes.
enough to get all those records.
Yes. Great. Thank you.
Okay. Anything else for Gary Z before we move along? All right. Next on the list is Paul Frieda.
Yeah. So I've had a recurrence. I took Lupron for 3 years and then went off it, and I got 5 years without any drugs, and I was undetectable all that time. But early last month, I came in at 0.13, and my oncologist said, let's wait a few weeks and try it again. And we did. We waited 3 weeks, went up to 0.17. And so I will be scheduled for a PSMA PET scan very soon. And we'll see what those results are, and then we'll decide what to do next. Also, I have a spot on my pancreas, and it's been there now for 4 years, and a CT scan with contrast just a few weeks ago came up clear. It's still stable at about 1 centimeter. So I'm doing good.
Well, I'm delighted that you got the PSMA scan.
No,
That
I
is
haven't.
very
I
good
haven't
news.
it's
No,
just
that you've arranged it.
yeah, right. It'll be in about a week or two.
Right. Is this through your guy, Dr. Schwartz, whatever his name is, Berger?
Dr. Schwartzberg, yeah, Abraham Schwartzberg.
Right. So there was no pushback when you asked for a PSMA.
No, not at all. They initiated the requests, so.
Excellent. Well, don't get too concerned, and don't tell us what the results of the PSMA are, and we'll take that in and we'll help you think through the treatments, and then you'll go in and talk and see what Schwartzberg says you should do. And are you going to see Schwartzberg
Yeah.
himself?
Yes, I did.
Himself.
I didn't see him today. I saw one of his assistants, who I like very much. But my next time I go in after the scan, I will be scheduled to see him.
For sure. You've told him that. That's all you want to see, right?
That's what she told me. She said, you'll see Dr. Schwartzberg after the scan.
Okay, well, they got to make an appointment for you after the scan, right?
Oh, where do I schedule the appointment? It's mid-January.
Okay, well, if they've scheduled that appointment, do you have a portal?
Do they have, yes, they do, MyChart.
Okay, so go into MyChart and say, I am looking forward to my appointment on January the whatever it is. I expect to see Dr. Schwartzberg. If he is not available, please advise me 48 hours ahead of time.
Okay, all right,
Okay? But
okay,
you've got to do that,
okay,
because they will at the last minute, they'll tell you, oh, sorry, he had to go to Tampa, or oh, sorry, he had to go here, or he had to go there, or he had to go somewhere else, right? And then
yeah,
you're going to come back to me and you're going to say, you know, I never get to see Schwartzberg and he's always going somewhere else. If you put it in your, it's all well and good her telling you that, but that doesn't count for much, Paul.
yeah, yeah,
If you put your expectation in that portal, and then if they mess you around, you've got something to go back on.
okay, all right, thank you.
Okay?
Okay, all right, good.
Welcome, Dr. John.
Thank you. Sorry I'm late.
Oh, you missed a terrific conversation with Dr. Bob about ketamine and psilocybin. You would have loved it. So you'll have to listen to the recording.
Oh, very good. Anybody get converted to the cause?
I don't know. You'll have to ask the guys here. Anybody get? Yeah, you can put your hand up. Anybody get interested in the psilocybin and the ketamine from our conversation?
Been
Len
there,
did.
done
Oh
that.
my gosh, Len did, and Mark Valens, and oh, so yes, there you go. There's your answer, John.
See the old hippies.
Yes. Oh, where's Larry Fish? Where's Larry? Did Larry leave us already? Well, then you've got to listen. Larry Fish admitted to being one of those old hippies who had done some of this stuff back in the day.
Yes, been there, done that.
There you go.
Julian, too. I can see a sparkle in his eye.
All right. All right. I'm going to keep on going here. We're doing pretty good. Oh, there was one thing I just wanted to mention to you. I just read an interesting article today. It isn't really for our space, but it was a report that came out in a conference going on this week about active surveillance for renal cysts. And a few of us have had renal cysts, I for one, and it was actually the renal cyst that probably saved my life and the reason I'm here today, because I was doing active surveillance on a renal cyst for several years. And thank God my urologist asked for a PSA test, and my PSA had gone from 2.5 to 10 because my PCP didn't believe in PSA tests. And so it was because of that renal cyst that they diagnosed my prostate cancer. But the gist of the article was that it is very safe to observe renal cysts, and the number of renal cysts under 3 centimeters that turn into cancer is something like 2%. So I know this isn't really what we talk about here, but I was encouraged by that article. I saved it, and if anybody wants it, I'd be happy to send it along. Okay, we're going to go. Here's where we're going to go now. We're going to go to General Joel. We're going to go to Jerry P. We're going to go to Dr. Jack, and then we're going to go to Len, because Len said he was good to go at the end. So, General Joel. Well, your mic is on. Your mic is on, but we can't hear you. Speak up again. No, we can't hear you. I'll let you troubleshoot a little bit, and we'll go to Dr. Who did I say? Oh, Jerry P. and then Dr. Jack. So we'll go to Jerry P. and then we'll come back to General Joel. Jerry.
Okay, this quick update. My PSA has been rising quite a bit and been following it, but should have done a PSMA earlier. But my PSMA is now 0.99, and that was done November 18th. So I will be having a PSMA test this Friday, the 8th, and also going to do a gene sequencing, and that'll be done on the 18th of December with Foundation Health. And then the other thing that Rick will like is on December 28th, I have an appointment with Dr. E at Houston Methodist. So I'm getting all set for that. So it'll be nice to have a new PSMA test at the time I visit with Dr. E. So that's where I'm at right now. Don't know what we're going to do, but I know we'll be doing something after that PSMA. So that's it, Rick.
A couple of questions. When did you say you're seeing Dr. E?
December 28th.
Oh, okay, right after Christmas. Second question. This sequencing that you're doing with Foundation Medicine, is it going to be a liquid biopsy, or is it going to be a liquid analysis or a solid tumor analysis?
It's a blood.
It's blood. Okay.
Yep.
I'm curious. Are they sending one of their phlebotomists over to you?
No, at Arizona Onc, they have Elaine is, I guess, a qualified person. She's the only one. She's the only one that'll take it, and that's why I had to wait until the 18th.
Well, you don't have to wait until the 18th because you can schedule something directly with FMI. They've got people that come out, and I don't think they charge you for it. So if you call, you can wait till the 18th, but you don't need to. It's your choice.
All right, I understand, but
by the 18th, you could have the results. And here's the problem. I would not wait until the 18th because it takes them 2 weeks to get the results, and you won't have the results when you go to Dr. E. So you need to get that done this week so you get the results back, because it will make your appointment with Dr. E a lot more meaningful.
So
and
I can
either
call
Arizona.
Wait a minute. So I can call Foundation Health myself, right?
It's Foundation Medicine, not Foundation Health.
Right,
and
Foundation
here
Medicine.
you've got two options, which is what I was just going to say to you. One, you call Arizona Oncology and you say you have to have it this week, and see if they'll put you in with your lady, whoever the lady is. I don't know what's so complicated about taking blood to send to Foundation Medicine, because they're just taking blood. That's it. There's nothing special about it. The second thing is you can call Foundation Medicine and tell them that that a test has been ordered, which you're telling me it has, and you'd like to use their traveling phlebotomy service. And they'll come out and they'll test you.
Okay.
And the number, I'm pretty sure I have the customer service number here for Foundation Medicine. Hold on a minute.
I'm sure I can get it on the internet.
Foundation Medicine, FMI. You definitely can, but if I've got it right here, Foundation Medicine. No.
While
Well,
Rick
if you
is looking
find it,
at,
just put it in the chat room because I'm
Okay.
done.
Okay.
Unless you've got another question.
Well, I don't, but other people might.
I had a question, Jerry.
Yeah.
Was the idea of doing this liquid biopsy yours or your oncologist? And did you, if it was yours, did you have any trouble talking them into it or anything?
Not really. I didn't have any real trouble into talking my med onc here into it. But actually, it all originated with a discussion with Rick.
Yeah. Okay, good.
And it's been 5 years, so I agreed. I mean, it makes sense. You know, I've been on Zytiga all this time.
Well, it makes sense to us, but I just was hoping that it made sense to your oncologist too, and it sounds like it did.
Yeah, I mean, he's not against it at all.
Yeah, cool.
I mean, yeah, you want I don't find it quickly, Jerry, but you want foundation medicine customer service.
Okay.
They're really good. They're really, really good. And
All
I'm
right.
sure you'll get it sorted. Any issues at all, let me know and we'll go through a back door, but you should be able
Well,
to get it
no, you
sorted
brought
tomorrow.
up a good point. I want to have that when I meet Dr. E, and I didn't think about that. So thank you.
Sometimes we come up with good ideas on the in
Oh,
this
I know you
group.
do.
You
I
know?
know.
It does happen. All right. Now, is that microphone of General Joel working or not? You're muted. Go ahead.
Is it working?
Yes.
Good. All right. When it comes to prostate cancer MRIs, CTs, bone scans, PSMA scans, and FDG scans, and other scans, I'm talking strictly about the CD now. Does anybody know in this room how to put the CD like that of the results of the scans onto the Epic MyChart system?
I do not.
That depends
I've
on
never
whether
tried it.
the radiology department that you used participates in MyChart. You know, MyChart is an optional computer record thing that people have to buy at very high price, and not everybody buys it. And
You mean
if
MyChart or
you're,
Epic? You're talking Epic or MyChart?
Both.
I think MyChart is the product.
Yeah, I think it is Epic. Epic
made
has
It is a
MyChart.
product.
Yeah, made by Epic. So I guess it's like Comcast and Xfinity or something like that. So if they don't participate in MyChart, then you're out of luck.
No,
I
all of my doctors all around the country do participate in my charts. I'm lucky that way. A lot of doctor staffs don't know how to do it, so I would like to do it myself if I could, because the doctors can't usually want to see the CD to analyze the scans, and if they
Yeah,
can't do it, then they're blind.
yeah.
Hey, Joel,
You
Yes.
can't do it yourself.
I use Fairfax radiological consultants, and they put the results from the full body bone scans and the CT on my chart under tests. So it's like a blood test, the same category.
Right. No, I understand that if Innova in this area or Houston, in the case of Dr. E, gives me a test, they automatically put it on my chart. The trouble
Okay.
is, when I get something done at Walter Reed or VA, I send the CDs over there, but they never get into my chart. So I'm wondering if I can do it myself.
I,
Myself.
I, I use Fairfax radiology consultants, and they put the results from the full body bone scans and the CT on my chart under tests. So it's like a blood test, the same category.
Right. No, I understand that if Innova in this area or Houston, in the case of Dr. E, gives me a test, they automatically put it on my chart. The trouble is, when I get something done at Walter Reed or VA, I send the CDs over there, but they never get into my chart. So I'm wondering if I can do it myself.
Nope.
I don't think
I don't
so.
know.
Okay, very good. I have called MyChart twice, the help desk, and they say no, patients can't do it. But I was hoping that some smart guy in this room could do it. That's why I
I've asked the doctor to put it in my chart for me, and he has.
okay. All right, thank you.
So the question I have is it the scans that they're doing at Walter Reed and the VA that you want in there, or is it the VA and Walter Reed you want to be able to see your scans?
No, it's the scans that I have done at VA as example, and they give me two CDs, one for me and one for the doctor. But I send it to the doctor, but it never gets into my chart. So if I could do it myself, then I would be glad to do it.
Oh my gosh, I see Eric left and I didn't get to him. Boo. That's my bad. Sorry, guys.
I don't
Josh
think they let you
Allen's
download
office.
stuff.
Josh
Regarding
Allen's office should do it.
regarding the my chart, I just had a situation where I had some X-rays done, and I talked to the doctor's office, and in the menu section, there's a tab called imaging, and you can go on there, and there's a phone number you can call, and they will you request them to download the image into MyChart. If you have a disk, then they'll give you an address to send the disk to, and they will download that disk into your MyChart imaging.
That's what I'm after. Thank you very much. That's just wanted to know how to do it. If there's any instructions on the internet, but you just told me how to do it. I appreciate that a lot. I've been able to download, by the way, Houston Methodist CDs without a copy of the CD. I've been able to download it to my own computer and give it to doctors in the Fairfax area, but I've never been able to upload a CD. That's what I'm really asking about. But you
So,
just don't. Go ahead.
Tony Fig, just repeat that one more time, how to upload a CD, please.
You can go on to MyChart menu on the left, and you scroll down, and there's a section called imaging, and you click on that, and there'll be they'll give you instructions as to a telephone number where you can call, and they have to uh, download the image into MyChart. They also have an email address where you can send a copy of your image to them, and then they will download it into MyChart.
When you say send a copy, can I send a literal digital copy of the CD, or do I have to send them the CD?
From what I understand, a digital copy will work because the X-ray I had was from a non University of Rochester entity, so they did send I had the imaging company send the disc to or send an image to University of Rochester, and then they did download it, so it can be done digitally.
Okay, very good, Tony. That's exactly what I was after. I appreciate it greatly.
Okay.
Okay. The magic of the AnCan wisdom strikes again. And Jerry Pelfrey, those numbers are all in the window for you for tomorrow, so you can call first thing in the morning. You see them in the chat window there? Well, he's muted, but hopefully he sees them. 888
Yes, yes, thank you.
3639.
Thank
There
you.
you go. Don't thank me. Thank Tony Fig and Julian. Okay. And I'll thank them too for covering my ass. Okay, Eric, I blew. That's my bad. I'll have to write to him later. We've got Dr. Jack and then Len. Dr. Jack.
Okay, I won't be long. I missed last Tuesday, but I listened to the recording, and there was something in the recording that sort of confused me. I'd like some clarification. I don't know his name. Wasserstein, is that his name? You know,
Wasser
the
Sug.
Wassersug.
yeah, the guy from Canada, the PhD. He started talking about you have to just learn how when you're taking ADT, which he did for 20 years ostensibly, and he said that you just have to adjust and you can do just about anything. He said you can do triathlons, you can do marathons. He started talking about it in such a cavalier fashion. I'm a former triathlete and marathon guy, and I've been an athlete my entire life, and I feel so frail now since I've been on this medication now for 8 months, whatever. And I cannot believe that there are people who, after 20 years of being on this medication, he's saying, are able to have such vitality and vigor when I'm feeling so frail, like I'm going to fall on my face. And I don't know if it's my illness, I don't know if it's my age, or whether or not it's just the medication plus all of the above. And I'm feeling sort of frustrated at his cavalier kind of attitude and how he made it seem like, it's like shooting fish in a barrel. You can do it if you really want to. And I found that very frustrating, and I just want a little feedback. Maybe I misheard it. Maybe it was something he didn't say, and I'm misinterpreting it and distorting it in some way. But did you guys hear anything like that last week?
Jim Marshall. Jim Marshall.
I heard that, and I believe it's true because of the fact I was on ADT plus Zytiga for 5 years. I was active. Now, it isn't easy because at times I would get tired, and the body says you can't do it. But the thing I did was to force myself to get outside, to jump on a bicycle and to start to pedal. And it was hard at first, but then essentially the more I pedaled, the simpler it got. And after about a quarter of a mile, it was okay to do.
Jim, I'm not talking about something that basic. I'm talking about extreme stuff. The stuff he talked about.
Extreme stuff, I am not about to try a triathlon, but I'm talking about aerobic exercise.
Well, I do that every day. Okay, but I'm talking about the way he spoke about it, like being able to do it like I did it, which I can no longer do, and I don't know if I'll ever be able to do it as long as I'm on this medication. And I don't know, I want to get a reality check from you guys, because I want to know whether or not, it's hopeless and I will never, anyway, as long as I stay on this medication. Yeah, go ahead.
So Dr. Jack.
How old are you, Jack?
Dr. Jack, I'm gonna give you a couple of responses here.
Please.
First of all, you should dialogue with Richard Wassersug yourself. I've sent you through the chat window. I sent you his email, and he's very friendly. He's very talkative, and you can probably set up a call and you can ask him. The second thing I want to tell you is when I went on ADT, I did exercise every day. I did continue to do some endurance, but could I do triathlons when I was on ADT? I don't think I could have done. I'd had to stop running. I was learning to row and I was cycling, but I did cycle long distances. The third thing I got to tell you, which is probably the most important, is could I do any of those stuff today? No, because I'm 73, unfortunately. And it takes me all my time to do an hour and a half in the house, jumping from my exercise bike to my rowing machine.
Okay, I get it.
And I can't do it.
How old is Wasser? What's his name? Wasserstein?
Wassersug he's older than me. He's probably somewhere between you and me.
So but he made it sound like it was so easy, and he's able to adapt. That's where I have
He's
trouble.
Canadian.
Is he bullshitting? Is he legitimate?
Look, look, look,
I'll
some
talk to
of it
him.
is easy, but some of it is, Jack, you ain't never going to be able to do those triathlons even if
I'm
you
not going to
weren't
do
on
that. I just want a
ADT,
little
as
more
much as
energy.
you'd like to.
The energy, I just, it's so exhausting. I push every day. I'm at the gym 3, 4 hours, but still, it's hard.
God
I'd rather
bless
be.
you. You come home and take a nap.
I can't do
I'm serious. Do you come home from the gym and take a nap?
that. No,
Well,
I
I
can't.
did. I will tell you that. I would come home I'd go rowing, I'd come back, I'd nap for 40 minutes, and I felt great after that.
Really?
I'm
Oh.
serious.
I'm afraid of doing
not
that.
being
I'm afraid.
facetious.
Yeah. I kind of got the impression you can't give in to that. You have to push through it.
No, well, you don't have to push through it. If you feel like you need a nap, take a nap, but don't take a nap for 2 hours or 3 hours. Make
No.
sure it's a shortish nap. I'm gonna get some feedback here. We got hands up. Peter Kafka. No, wait a minute. Peter Kafka, did you want to talk? You don't have your hands up. Len Sierra and then Jeff Marchi, and then we'll go to Dr. John, because I think he's probably got something to say on this too. First,
Okay,
first,
yeah.
Len.
So two things. First of all, Jack, I kind of agree with you. I thought he was being a bit cavalier, and I don't think he was talking about his own personal experience running half marathons or marathons. I think he was just speaking in general about others being able to do it. Second thing, and maybe Rick can tell me if I'm right or wrong about this. I'm not even sure he was ever on ADT. I think he was always taking high dose estrogen, and he paid a price for that. He had the boobs to prove it, and he had a double mastectomy. So I mean, but I'm not sure he was ever on ADT, or if he was, it was only for a short while.
Well, that's a different ballgame.
And also, I don't think he was. I don't know what his Gleason score was. I think he was more like intermediate rather than advanced. Do you know, Rick?
I don't remember. I mean, I'm sure
Yeah.
if you look at his book, I could dig his book out here and it would tell me. But I
Yeah.
think he was on Lupron originally and he couldn't tolerate it, and that's why he went over to um, that's why he went over to the estrogen. But he did it many, many, many years ago.
Right.
And I don't know what his original Gleason score is, but if you look in his book, and you'll find that out. Peter's entering for the Special Olympics next year. Anybody here want to join with him? We're having a new category, ADT category for the Special Olympics. Right, Peter?
Right, if I can make it.
Jeff Marchi.
I think part of this is just your basic constitution. I'm 76. I've been on Lupron for 6 years, ADT for a couple and abiraterone for 2.5. The only time I have felt tired was when I stopped prednisone and was real fatigued for 2 or 3 weeks. But I walk a couple of miles every day. I could walk more if my knees weren't bad. I've always been hyper. Uh, I just had always had a hell of a lot of energy, and I think that's part of the thing that it varies from person to person depending on their constitution
Well, I've
and
been just
how
like
they're.
you, Jeff. I've been just like you, tons of energy, and you know, it's depleted now. I'm unplugged. I've never felt this way before.
Yeah,
So God bless you. I wish I had that, whatever you have, that prevents you from feeling like me.
Gary Z. Unmute.
Thank you. Yeah, just sharing that at the time of my diagnosis, I was 56 and I was very overweight. So a few months after surgery, my primary doc read me the riot act, said, get a personal trainer. I did. I lost 33 pounds in 5 months. But most importantly, I've always liked aerobic exercise and weightlifting, but I was doing so many things wrong. I realize I'm talking several of our brothers here are medical doctors or health professionals, or obviously just very knowledgeable. I was also very lucky in that my employer, there was a group, sort of group physical exercise class, so I was able to see this personal trainer for very reasonable cost. I realize they can be very expensive. So I'm just sharing that that was super helpful because, boy, it's not just aerobic exercise and reasonable resistance training. There's a real science and a right way to do it. And I'm 66 years now. It's been 10 and a half years since my first diagnosis. So I was just throwing that out.
Okay, I'm going to say a couple of things, and we've got to get to Lennon. Don't leave because I got something to say at the end. Please, just hang in, but bear with us. Dr. John, do you have any words of wisdom for your fellow psychiatrist in this group?
Well, I'm sympathetic. I mean, just because Richard knows of 2 people that did it doesn't mean there aren't 500,000 people that can't do it. I mean, we all just got to do our best. Asking our bodies to adapt to exercise at high level without any testosterone is a very, very hard ask. Nevertheless, we all got to just do what we can.
Thanks, John.
Thank you, John.
I think the best thing to say to you, Jack, is please stop beating up on yourself.
No, I just don't. What he said really bugged me.
I know,
it just seemed
you gotta stop beating up on yourself, and only you can do that. I don't have to tell you that, but you're doing great. And seriously, come home, take a nap after you. I know how much. I would exercise for 45 minutes to an hour at the gym, and I would come back. I was exhausted. And I felt, okay, I'll go lie down 30, 40 minutes. And then I was like a new person. And this is whilst I was on ADT. And that was pretty much my scope every day. I said, my job is to exercise every day. That was my job. That was my job. And I allowed myself to do it. And then I did what I had to do. And I felt much better for it. And God bless you. At your age, I probably don't have as much energy right now as you have. I've got to get down. I've got to get down and see you. And David Muslin and I are going to come over and sort you out. I tell you, you're going to be in trouble. We're going to get on his boat and go down to Key Biscayne and sort you out. Right, Mr. Muslin?
I'm waiting, David.
Okay.
All right, Rick.
Now,
great. Thanks, guys.
Okay, but really, go easy on yourself and allow yourself to rest. You don't have to push through it like that. You have to do the exercise. You have to push through to do the exercise. But don't beat yourself up. If you feel you need to nap, whatever you need to do, do it. Please.
Yeah. All right. I'm going to look up his name. Yeah, I'm going to look up his name on the chat. Richard.
Okay, he's there. And the other thing, which was a great suggestion from Gary Z, as much as you think if you can find a trainer who has the sports medicine, certification for cancer, work with them once a week or twice a week to give you the routine. Let them make a routine for you because they know how to work with people that are on ADT. And,
but you don't have to pay for it. You can go to a PT, a physical therapist. The same thing
not really.
Yeah,
because the
same thing happened to me. I wasn't doing things right. And she was able to tell me and show me everything I needed to do, and I love it. It made me do it more.
Okay.
That's my point.
But all I'm saying is not all physical therapists will do it because sometimes, if you get a referral for ADT, maybe they'll do it. But the physical therapists don't necessarily understand ADT. But for Jerry, it worked out great. But I do like the idea of you getting somebody who understands ADT and putting the right program for you. You may be over exercising 3 to 4 hours a day. It sounds like it. And maybe that's why you're so fatigued. It could be, Jack, we don't know.
I got it. All right, good. Thanks. I'm going to look up this guy's name and have a conversation with him.
Okay, you have a conversation with him and go find yourself a good trainer there. Now, a very quick one from my fratello Len, and then I'm going to say something. Go ahead, Len.
Okay, I guess I'll just say that I'm still waiting on a radiation consult from the University of Miami. No longer holding my breath, but it's not as important anymore because I just had a PSA check after being back on darolutamide monotherapy for 5 or 6 weeks, and my PSA went down from 0.17 to 0.06. I guess one question I had though was, is that too low now for me to ask for a liquid biopsy? I think you have to have a little more action going on.
Well, I think the answer there is it depends on your level of metastasis. And when was the last time you did a PSMA scan?
Oh, it was just October 4th. And I
Okay.
had, everything was sub-centimeter in size, but I had a couple of pelvic lymph nodes. I had one at lower para-aortic, which was lit up at SUV 25, and a lymph node in the left pelvic wall at 20, and two questionable bone mets in pubic bone, left and right side, which were like 3.1 SUV.
Well, so the answer, I think, and I would ask both Dr. O and Dr. Guanciale, it's not a function of your PSA so much as it is what level of metastasis you have, because these cells that they're picking up are coming off of the metastases. Now, we know that if you're in a recurrent situation for the first time and you don't know what you've got there, a low PSA isn't going to do it. But if you've got a man who has a lot of metastasis, but his PSA is low because he might be on ADT, you should still see those cells are still dying.
Okay.
Right?
Yeah, I'll talk to them, see what they say.
Okay, so let me
Len?
quick before people
Len?
leave.
Can I ask Len a
Just
quick
before
question, just very quickly? How long were you off your
Harry,
medication? Len, how long were you off your medication? Just curious.
What was the question?
how long were you off your meds?
Oh, 21 months.
21 months. Okay, thanks.
We can come back, but here's what I want to say to you guys. Tonight's meeting is a fantastic example of the value of an AnCan support group. Because if you look down and see how many people are saying, oh my gosh, I didn't realize I could do that, or I didn't realize this would be important, or that would be important, or where I'm going to find a doc. We create so much value added for the people that come in here and the people that listen. And I want all of you to remember that, because our fundraising, end of year fundraising letter is going out. We don't push you at all during the year. God bless you all. But just remember what we do for you when you come into these meetings. It's a lot. And we rarely say this at the end of a meeting, rarely say it. But now is the time. David is our fundraising chair this year. David, do you want to add anything? David Muslin.
It's pretty hard to add anything to that, Rick, because I don't think you need to convince everybody that the value that we bring to AnCan. But the goal is for us to grow AnCan beyond our founder, Rick Davis. And if we want AnCan to keep giving the gifts that it's been giving to us, we need to support AnCan so it can grow.
Oops, he froze.
I think you froze, Dave. What a time to freeze. That reminds me of a joke,
Roll.
which I won't tell. Oh, you're back. No, you're back. David, put your mic on again. You froze in
Yeah,
the middle.
I think what I said, I don't know where I cut off, was everybody knows what AnCan gives. And if we all give back a little bit, AnCan continue to grow and help the next set of men behind us. And that's what it's all about. And we need to
Right.
support AnCan, and AnCan's got to grow beyond Rick Davis.
Right.
And
Thank you
thank you.
so much. And this also goes for all the guys that listen on the recording, all of you who are listening on the recording who don't come into the groups. Please don't forget us. If you're on our mailing list, you're going to get that. You're going to get a letter in the next 24 to 48 hours. Please don't bin it. Read it through. You can bin it after you've read it through. You can choose not to donate, but read through what's in the letter at least. That's all we ask. Harry Spear, anything else you wanted to ask Len about his darolutamide and how long he was off?
I was just curious because I'm taking darolutamide and I was contemplating maybe going off it, but I know Len kind of has a similar story to mine, so I was just more curiosity than anything.
Okay. Well, you can always reach out to Len. He's very good about responding. Len@ancan.org. So,
And Harry, I don't know if you know this, I was on darolutamide for about 2 years before I went on the drug holiday. And then I came back on it now, and I'm still sensitive to it. So that's a consideration. Good.
Yep, that's good. Good.
okay, guys. Well, we got through everybody.
Excuse me, Rick. Jerry Pelfrey has a question that needs to be answered now about going to see Dr. E and staying in a hotel. I believe General Joe knows all about that.
Yes.
I thought you go to Dr. E too, don't you, Jim?
Negative.
Oh, I'm
Eventually,
sorry.
I probably will, but it's General Joe. I am Captain Jim.
Okay.
Okay.
Yeah.
Yes, I've been, and I'm going back to Houston on 21 March, see Dr. E and take some scans. And what you have to do is you have to stay at the extended stay motel, extended stay suites, I guess it's called. But you have to call the American Cancer Society to make that reservation. And basically what they give you is 50, 60% off. I paid like $45 a night for 4 nights last time I was there in
Wow.
August. So also, American Cancer Society has 30 of its own hotels that are totally free to you, providing you can get in. So you need to call the doctor's nurse navigator and say, "Hey, I'm going to be in Houston, and can you get me into a American Society hotel?" They'll confirm whether they can or not based on the dates you're going to be in Houston. And they even have a bus, a little van or bus that transports you between themselves and Dr. E. It's only a couple of miles, I think, or you can take Uber. Uber is very convenient in Houston. So those are your choices.
Okay. I had never thought of the American Cancer Society, so I will call them.
Yeah, they're the ones that give the break to the extended stay suites, and they're the ones that have 30 hotels, one in Puerto Rico, the rest are in the continental U.S. major
Yeah.
cities.
Yeah, I've used them, when I was traveling a lot, but I never thought of the American Cancer Society. Thank you. I don't want to take everyone's time up, so I appreciate that. Sorry, Jim. Thank you, Joel.
You're welcome.
Okay. Thank
No
you,
problem, Jim.
everybody. We're back next week with Peter Kafka in Maui in the chair on the Tuesday next week, the 12th. So we'll see you all then. Thanks everybody. Good session. Good night.
Thank you so much. Good night.
Good night. Good night.
Thank you. Good night.
Right.